because I'm sure you're going to talk about those more in pharmacology. Nitrates, again, beta blockers, calcium channel blockers. Talk more about that in your pharmacology class. All right. Clear as mud. See, we just did a lecture that I could probably lecture on for about 3 hours in 5 minutes. Yeah, 6 minutes. So, yeah. We may have to break this up into another lecture if your pharmacology class, pharmacology lectures don't cover this in more detail. Because this, I mean, this is truly a pharmacology intervention driven thing. I mean, there's some signs and symptoms and differentiating between the etiologies of the hypertension, but ultimately a lot of your intervention is going to be all pharmacology based. So if you get a really good detailed pharmacology lecture, you can log that out of there.
2 week getting 2 from Dr. Brin.
Good, good, yeah. So we'll talk about cardiogenic hypotension. There's a lot of different hypotensions out there. Neurogenic, anaphylactic, traumatic, hypovolemic. There's all sorts of different hypotensive crises. But since this is a cardiology lecture, we're talking about cardiogenic hypotension. And so there's you're classified as a solid less than 90 or math less than 60. And so, there's some general definitions of what shock is, what cardiogenic shock, cardiogenic hypotension is, things like that. So MI, severe right ventricular failure, kind of like what we talked about, or heart failure, severe left ventricular failure as well can cause you to be hypotensive. Arrhythmic is another one that people don't really think about a whole lot. SVT, heart block, bradycardia, defib, VTAC, obviously, and AFib, RVR. A lot of different arrhythmias can cause you to be hypotensive. So your treatment in those situations are going to be different from these. Here, you want to concentrate more on constriction of peripheral arterial vessels to increase your blood pressure. Here, you want to focus your attention on arresting the arrhythmia that's causing the heart to fail as a pump. So these are going to be 2 different treatments. And then mechanical failure if you have an actual valve that's not functioning correctly, or your heart muscle explodes, which happens. You can have ventricular rupture if you're have transmural infarction and it just explodes. Cardiac tamponade, that's more of a traumatic tamponade. I think we'll cover that's included in this one. So again, hypotension, tachycardia is going to be your early compensatory mechanism. You're always going to see an increase in heart rate because you have decrease in cardiac output. You got to change one of those 2 things, stroke volume and heart rate. If your problem is a stroke volume problem, you're going to try to increase your heart rate to compensate for that. So that's going to be an early thing. Oliguria, if you're not perfusing your kidneys, you're not going to produce urine, so that's going to be significant. Neurologic, obviously, if you're not getting blood to your brain, you're not going to be as awake or snappy as you normally are. Lactic acid, VO, troponin, and all these other ones are just going to help kind of guide what's going on, but it's not necessarily going to be dependent on treatment. Cardiogenic shock secondary to MI. So dopamine and Levophed. This Levophed is your go-to. That's going to work 90% of the time for everything. For neurogenic hypotension, for cardiogenic hypotension, for you name it, hypotension, shock, hypotension, sepsis, hypotension, you name it, Levophed is going to be a right answer. If you ask, well, what kind of peripheral vasopressor? So another term we use is pressors. So he's talking about a pressor that they're talking about a medicine that will artificially elevate your blood pressure by constriction. Levophed is going to be your right answer. It used to be dopamine. Dopamine and dobutamine were kind of your go-to ones for congestive heart failure, for cardiac-related hypotension, but they've done a lot of studies and stuff now that say Levophed is superior and easier to use. So Levophed is, if you get asked what pressure you want to put them on, Levophed is going to be your answer 9 times out of 10. The few times that it's not going to be your answer is very specific situations like anaphylactic shock. You want to use a more epinephrine than you would Levophed, which is norepinephrine. Although you probably could use norepinephrine because it acts on the adrenergic receptors as about as much as epinephrine does. But so Levophed is going to be your go-to. You can also use dopamine or we have dopamine on there, are also go-tos as well. So all of these other cardiogenic shocks secondary to arrhythmias and heart failures, again, I could give a 2-hour lecture on arrhythmias that cause hypotension. You'll talk more about that in AFib, heart block, ventricular tachycardias, different things like that, prolonged QT syndromes. So those are going to be not necessarily treated with vasopressors. They can be treated with other medicines or defibrillations to treat the genesis of the arrhythmia, if that makes sense. Oh dear God, here, just read about that later. Orthostatic hypotension, I mean, that's pretty basic stuff. I'm positive they're going to talk about orthostatic hypotension at another point sooner or later. What's going on, so. You guys got any questions over this? I know that was kind of your down and dirty, and it was difficult to do it all in 10 minutes. But, you know, if these things are very specific to a certain type of medicine, I don't expect you to come on rotations and know exactly what vasopressor to start, how to start it, when to start it, what's the best one to use, or specifically what medicines that, you know, you should have a general idea on how to treat hypertensive urgency and crisis, and I know you're going to get a pharmacology lecture on that, so you should have a better understanding of that. But those, the hypotension crisis and things like that, those are very specific to critical care and emergency medicine. It's not expected from me that you guys know everything about that or even have some cursory knowledge about it. We'll discuss more about that on your rotations, or your other preceptors will, as on a need-to-need basis. You're not going to have a whole lot of questions on pants about that sort of thing, I don't think. Even if you do, it's going to be one question, so not going to be a big deal. Other things that you need to know more about: acute coronary syndrome, how to treat arrhythmias, things like that. Any questions? I think that's it. No? All right. I will send you out. Let's see, I need to send you out the EKG lecture, and then let me go and look up the left frontal branch block stuff, and we'll send you out. Was there anything else I needed to send you?
That lecture right there that you just did.
Oh. And I also have a handout that's associated with this here. I'll just send it out right now. All right, that's it. Good job.